Thank you for that introduction and for the invitation. So there's a lot of hype about this, and so I hope over the next 45 minutes or so to talk in a bit more detail about where that hype's likely to end up and not be too disappointing in the process. I should warn you, though, that I've a number of conflicts of interest. I've received funding. I work a lot with industry, and I've received funding. I'm not doing that, by the way. I received funding from a number of companies in the field, and I work with our molecular diagnostics center on commercializing circulating tumor DNA tests for use both in clinical trials and in clinical practice. And we've also, and I'll touch on this work towards the end of the talk, a social enterprise set up in East Africa looking at using it as a way of diagnosing cancer in the field. So just to go over what I'm going to talk about, I'll start briefly by talking about what we mean by measuring circulating tumor DNA, what we mean by ctDNA, as we call it for short, and then think a bit about where we might apply it in terms of detecting cancer. And for the second half of my talk, I'll talk about that in some detail, how we use it or could use it to assess the effects of treatment, although that's not my own research. Look at where we can detect relapse after ostensibly successful cancer treatment, and then how we use it or could use it to study tumor evolution, which is important because it's one mechanism by which tumors escape control from drug treatment, and therefore could be a way of directing how we change our treatments rather than waiting to see them fail definitively in our patients. I'll talk in some detail about multi-cancer early detection tests, which are very exciting, have very large-scale trials going on in the NHS at the moment, and are probably the earliest at-scale application that we might see, with the potential for hundreds of thousands of tests to be deployed in the next few years in the NHS. And then briefly, I'll talk about how we might apply this technology outside of the UK. So circulating tumor DNA, as its name suggests, it's DNA that's shed by tumor cells, usually when they die, and they end up as small fragments in the bloodstream. And the tumor part of that is mixed in with a whole other bunch of circulating free DNA that comes from other cells that have died in the body. All of this can be extracted from the blood in plasma and isolated, and then sequenced at scale, and you can pick your sequencer of choice, and I'll show you some of the available possibilities. And then there are a couple of things that you can do. And essentially, we take two different approaches to circulating tumor DNA. If you want the greatest sensitivity, then if you've got hold of a piece of the tumor, because you've already diagnosed that in your patient, then you can study that in detail. You've got a lot of tumor DNA material against which to compare your circulating small fragments, and you can essentially match that via a number of complicated statistical and analytical techniques. If you haven't got tumor because you're screening somebody who's not got a cancer diagnosis, or in my field, you got a small cancer at the back of the eye that we treat with a radiotherapy plaque, so we never actually extract it from the patient, then you have to take a tumor uninformed approach, as we call it. And there, essentially, you're going to use a classifier and large numbers of samples in order to say, well, this is a cancer sample, this is a non-cancer sample. Machine learn your way to telling the difference with pre-specified accuracy. So that's the broad approach. And then why are we excited about this? Well, I just want to walk you through what we would normally do in order to understand the DNA of the cancer in a particular patient. You'll either have a biopsy or surgery to remove the tumor. And all of these steps require a certain level of skill. I'm a physician, so I'm usually moderately contemptuous of surgeons, but I have to admit that there is a certain level of skill in removing a tumor from a patient without killing them. You then have to be skilled at cutting up the sample when it arrives in the lab. It needs to be fixed, it needs to be processed. And what we've learned from the genomics revolution is that these relatively or ostensibly relatively simple steps are really good ways of messing up a sample and giving you misleading information. So that has to be done extremely carefully and faithfully. It then needs to be studied under the microscope. It needs to have the tumor tissue identified, although this is increasingly automated now. Then you can extract the DNA, and then you can start to analyze it. So the idea that we could get a liquid biopsy and go from the top left straight down to the DNA extraction is extremely efficient if we can make that work, and if we can show that it faithfully reproduces what you get by going the long way around. So as I said before, there are different approaches to this that are either tumor-informed or tumor-agnostic. With a tumor-informed, there are a variety of different techniques that you can use. At its very simplest, and there's an example of this that I'm going to show you later, which is why I bring this up, you could just study one gene that's altered in tumors. So in melanoma, one of my interests, the MAP kinase pathway, a growth factor pathway, is obligately upregulated in all melanoma cells. And there's a small number of mutations that can achieve that, the most famous of which is a mutation in the B version of the RAF gene, so a BRAF mutation, which drives the tumor. And so you can study that, and it's almost always the same mutation at the same point. So using a digital droplet PCR purely to look for that, if you know it's in the tumor, will allow you to track the tumor relatively straightforwardly. And then there are more complicated and bespoke personalized and multi-mutation or epi-mutation approaches that can be used. With a tumor-agnostic approach, you can take a panel-based approach, so predicting what a panel of genetic lesions or epigenetic lesions that will be found in a tumor, or you can use a classical trained classifier approach, which could be white or black box. Therefore, you may or may not know what's going into driving that classifier call for cancer or not. And I'm going to give you some examples of each of these during the course of the talk. So as well as this, and this is really a slide to tell you what I'm not going to talk about, there's a whole bunch of specialized kit with multiple variations. And if you go and talk to, lab scientists are very much like statisticians. If you want 6 opinions about something, then you go and find 3 lab scientists, and they'll tell you which is the best of these machines and which is the best informatics approach and why only their cloud computing solution is the one that works in this thing. And they're all wrong because you can do it in a number of different ways. And this is beyond my capability and the topic for tonight. So if we think about circulating tumor DNA and get back to the title of the talk about how this is going to change cancer care, then I'm pretty confident about the first bullet point because the hematologists have been doing this for years. Now, if you want to know what a hemato-oncologist is, it's basically an oncologist doing only the easy bits. All of their cancers are in the blood, so they can just nip in there and sample it, or just in case that's not the complete picture, they can pop a big needle into the bone marrow and take a sample out of that, and that tells them what's going on. And then compared with solid tumors, which are what oncologists deal with, their tumors are nice and clean. They're often driven by a relatively small number of mutations. They're often quite clonal, whereas solid tumors are by and large an absolute mess. So next week, you'll have a hematologist who'll shoot all that down and tell you about how their bit is way harder than anything I do. But they've been doing this for years. They've been able to, because they've got these clonal tumors with highly repeatable lesions in them, they've for years gone looking for the presence of those lesions in the blood as the earliest possible sign of the tumor coming back. And in a lot of hematological malignancy, they've got this sort of get out of jail free card. It's not really a get out of jail free card, but it's a sort of, we can always do a bone marrow transplant if the need arises, as a sort of way of trying to get ourselves out of trouble, provided you're fit and well, provided you're under 60 and prepared to accept that one time in 5 we might kill you in the process. But it's a sort of escape route that you can take, and therefore it's worth looking for trouble if your first shot at treatment doesn't work, because there's something you can do about it. We're kind of getting to that stage in solid tumor oncology, so we're now increasingly interested in finding trouble earlier because we've now got the tools available to us to do something about it. When I first started treating melanoma in the mid-1990s, none of the treatments worked. And so quite a lot of what I did was very carefully not looking for trouble, because once I found it, then there wasn't very much I could do about it other than make the person involved slightly miserable before they had symptoms, and perhaps it was better to wait until that was clear. So that, I think, is highly likely, and we're already seeing evidence that this is going to be one of the ways in which we do this. And I'm going to talk about 3 clinical trials in which that's happening or has happened already. The other way in which we're interested in using it is to assess the effects of treatment. So Nick Turner, who's based at the Royal Marsden Hospital, has been doing this for some years in breast cancer, is able to show that you can get very, very rapid loss of circulating tumour DNA after starting chemotherapy for breast cancer, within days to weeks. And this is much quicker than waiting for lumps to shrink on a CT scan, and probably quicker even than waiting for the patient to feel better because those lumps are shrinking. So you could get a very early impact. But that brings me to one of the problems that we have with using blood tests like this. They're pretty abstract. So it's all very well, using Nick's data to say, okay, I can tell quite quickly who's not benefiting from chemotherapy. But to say, okay, the blood test says we should stop this and do something else is quite hard. Whereas when you've got a CT scan and you can see the lumps aren't shifting or they're getting bigger, everybody understands that, can follow that. And so, what tests show and what you can then sell, if you like, though that's a slightly glib word for this situation, what you can share with a patient in order to make a decision together are 2 different things. And that's a problem that we're going to come up against repeatedly with this technology and similar blood tests. But most excitingly, and what's being tested at scale at the moment, is whether we can use it as the basis for detecting cancer, and in particular for detecting cancer in people either with no symptoms or very vague symptoms that all of us in this room are going to experience in the next 12 months. And at the moment, absolutely for very good reasons, do not trigger investigations for cancer. A bit of tummy ache, a bit of weight loss, a bit of breathlessness that doesn't sort of stretch beyond the point where we want to take it to the GP to see what it's about. And as I mentioned before, we may get around to studying tumor evolution, but I think that's very much the stretch task for this technology at the moment. So I'm going to take a step back now and talk a little bit about how we treat cancer, because I'm told this is a general audience, and so I don't want to take anything for granted. And having been rude about surgeons, I do have to point out they're the people who cure cancers and have historically over the last 100, 150 years that we've been treating it systematically. And their surgery's got ever more sophisticated. Bottom right here, you've got robotic surgery now. And when I was training, it was all about keyhole or laparoscopic surgery, and we now don't just use knives. We heat, we freeze, we blast with sound, and all sorts of other techniques as well. But essentially, we try and chop tumors out if we possibly can. And most of the advances in surgery are about doing less surgery so as to spare normal tissue from the consequences of doing that. And if we can't operate, then by and large, we'll try and irradiate. And that's the other way in which we've generally, until the last 10 years or so, been able to cure cancer by either chopping it out or irradiating it. But both of these treatments have consequences, particularly if people start to live longer, as they're doing now. And we know that half of people will now survive for more than 5 years after a cancer diagnosis. And so the long-term effects of treatment become important. And then, if this is the mainstay of treatment, then drug treatment has generally been reserved for situations in which the other treatments don't work, or as an adjunct to surgery and radiotherapy. Although that's slowly changing with the advent of immunotherapies and a bunch of similar drugs, antibody-drug conjugates, bispecific antibodies, that appear to be able to cure people without the need for operation or irradiation in certain circumstances that currently we can't predict on an individual basis. So, it's an interesting idea, but not driving the way in which we treat people generally. So if we think about that, then how is ctDNA going to play into this? Well, it's probably going to have relatively little to say about the cutting out bit or the irradiating bit, at least at the moment, because that works pretty well. But it may help us to refine our concept of risk in terms of whether we want to give drug treatment on top of it. At the moment, we use a lot of adjuvant therapy, so treatment with drugs after surgery or radiotherapy to prevent or to push back relapse. And by and large, the number of people that we treat in order to save a life will vary between, in the most effective treatment case, maybe 2-3 people, up to sort of 8 to 10. When it gets more than that, treatment either has to be super cheap and relatively non-toxic, or it's not going to be cost effective, both in terms of pounds and pence and in terms of the impact it has on patients and the general population. So there's a lot of interest in how we can use that, and a couple of the trials I'm going to talk about now will go over that. We've also got, as I touched on earlier, more and more people surviving cancer. When I first started training in the 90s, if you got 3 cancers, we packed you off to the geneticists to see whether there was some sort of familial or inherited characteristic that gave rise to this. They won't even look at you now unless you've got at least 4, and preferably with a few family members as well. And that's a reflection of the fact that more and more people are surviving cancers, therefore you've got more chance to go on and get another one further down the line, particularly if some of the treatments we've given you for the first 1 or 2 cancers increase your propensity to cancer later, as most of our drug and radiation treatments do. So at the moment, we monitor people when they come off treatment with scans or using their symptoms, and that involves a bit of radiation, quite a lot of technology, worry, and so forth. And we're very interested, therefore, in whether we can use this as the basis for replacing that, as well as assessing the effect of treatment. So to come back to the adjuvant question, this is an example from bowel cancer, and mindful of a general audience, I spared you a picture of a bowel with a cancer in it, and the usual thing that we like to show. And so this is a study of people who had stage 2 colon cancer, which we chop out, and then we worry about whether they should have chemotherapy afterwards. And we worry because of the graph on the bottom left, which, as you'll see, we've got everybody there on the left. It's a Kaplan-Meier curve in our jargon, so 100% of people are there after their surgery. And then as time goes by, measured in months, they're out to 4 years. As people who recur, as people recur, the line drops down. But what you'll see there is that the vast majority of people, maybe somewhere between 85 and 90%, don't have their cancer come back. And therefore, we're a little ambivalent about loading chemotherapy onto them because the outcome's pretty good already. So what this trial, which I'm not going to go into any detail to, looked at was it took about 450 people, 2/3 of whom had chemotherapy driven by a ctDNA test saying whether it was, whether they could find evidence of cancer after the surgery, with blood tests taken at 4 and 7 weeks, versus people who had the standard met-an-oncologist, had a discussion with them, decided whether or not to have chemotherapy. So 2 interesting things. First of all, if you have a negative ctDNA test, and this is across the whole study now, not looking at the randomization, then you do a lot better, which is reassuring, because if you're going to use the test to guide what you do, that better be the outcome. And then secondly, on this side, what you see is essentially a statistical treatment of the evolving difference between the 2 study arms over the course of the trial, essentially showing no difference. And in the 150 people who didn't have the ctDNA test to guide treatment, about 30% had 25-30% had chemotherapy. And in the 300 in whom they did have the ctDNA, only 15% had chemotherapy. And then if you look at the people who didn't have the ctDNA test, most of the time when they gave chemotherapy, they gave only 1 drug. And then in the other arm where ctDNA was guiding it, most people had chemotherapy with 2 drugs, which is more toxic, has a better outcome. So, pretty strong evidence, which is why it got in the New England Journal, which is kind of our sort of blue chip. If you're a basic scientist, it's the nature cell science of clinical practice. So, showing that it really is changing behavior. It's meaning that when you give chemotherapy, you give it like you mean it, and you use it much more sparingly in this population. So that points, I think, to one of the big ways in which we're going to use it. In my field, we're very interested in using this as the basis for giving it to people who've had a melanoma chopped off, where we know that we've got some effective treatments, which we generally reserve for a situation when we can no longer do surgery, but for which there's some evidence that if we use them earlier, we might get a better outcome, but we have to treat an awful lot of people in order to achieve that. And then the other thing we're interested about in melanoma, as I touched on before, is that we've got a relatively discrete set of mutations that we can use to track over 3/4 of patients and look very specifically for relapse with pretty high precision. And one of the reasons we're interested in this is that surgery is very good for melanoma. It'll cure about 90% of people. But what you end up with is a very large number of people who have a relatively small risk of relapse. And what that means, though, is that a significant portion of the melanoma deaths, about 1/3 of them, happen in people who after surgery have a risk of less than 5% of succumbing to their disease in future years. So it makes it very difficult to allocate treatment properly and to have satisfactory discussions from the patient's perspective about risk and how to manage it. So what we want to do is to say, well, okay, well, let's use circulating tumor DNA to do this. And essentially detection is set up as a national trial in order to look at mutations in these 3 particular genes. And then the outcome of the ctDNA monitoring will either be disclosed to the physician and the patient or not in a way that's randomized in order to look for a difference in outcome between these. And then we're also doing this in uveal melanoma, melanoma that starts in the eye. And I just mentioned this really to talk about why we decided to use ctDNA in this relatively rare setting. It's based upon a drug called tebentafusp, which is a bispecific molecule that attracts the immune system to cancer cells and kills them. And over many years, we did early phase trials, largely based in Oxford, but also around the UK, including here in Cambridge, from a spin out from the University of Oxford, that showed some activity in patients with uveal melanoma. And I'm not going to bore you with our various plots. What's important is this drug is now licensed across Europe for treatment of uveal melanoma, melanoma that starts in the eye, because it halves the risk of death, as shown here on the right-hand side. And rather than go into Kaplan-Meier's, if you're familiar with them, you'll see that there, and I'm not going to bore you with the explanation otherwise. But yeah, it's a pretty significant output. But when we went and measured the lumps in the patients using conventional CT scans, even in the good arm, the people who did best, the blue arm on the right-hand side there, less than 10% of people had a response, a formal recognized shrinkage of tumors according to international criteria. Slightly higher proportion had a bit of tumor shrinkage, but we specify that we don't call it real in clinical trial terms unless it shrinks by about 30% and stays shrunk for at least 4 weeks. So what it tells us is that here's a drug in whom looking at whether the tumors shrink isn't enough to tell us what's really going on. And this is a problem that's common to a lot of immunotherapies, because when we give cytotoxic chemotherapy, it's a poison, it kills cells. If the cells die, the body mops them up and the tumors, the lumps get smaller. If you give an immunotherapy, it might shrink the tumor, but it might send a whole bunch of immune cells into the tumor to attack it, and the tumor might expand briefly before shrinking, or it might expand and then fibrose and stay the same size, but with no active tumor cells within it. So cross-sectional imaging, CT, MR scans won't necessarily tell you the whole story, and I think that's the message here. What we did see, though, is that if you measured ctDNA, and they did this fitfully in this trial of 300 patients, so it wasn't done systematically in every patient all the time, and they hadn't got the assay developed when they started, so they developed it in flight. So a relatively small number of people had serial samples and were able to be classified according to whether they had the marker and it was cleared away, the green line. They had the marker, but it got worse, so more ctDNA developed during the course of the study, or they never had ctDNA in the first place. But what you can clearly see is that circulating tumor DNA is better at predicting who benefits from this drug than doing lots and lots of CT scans. So that's one of the reasons why we wanted to do a trial looking at whether, if CT scans don't tell us what's going on in people who've got lumps, well, maybe ctDNA is the way to guide this treatment in all circumstances, not just in people who've got lumps. And that's essentially what the trial does. And just to sort of close the loop back to some of the stuff I was talking about at the very beginning, this is a tumor type where we don't have the tumor. So we have to take a tumor agnostic approach. It's not quite as straightforward as skin melanoma, where you can rely on about 3 genes. But if you've got about a dozen genes in a panel, then you can look at a bunch of hotspots and pretty faithfully pick up who's got tumor cells that are shedding DNA or not in the circulation. So that's now up and running. It's going to involve over 800 patients. It's also going to have some people with skin melanoma as well. And we've treated the first couple of patients who've just got a ctDNA mark rather than lumps on a scan as the basis for triggering immunotherapy. And one of the reasons that we're keen on this approach as well is that there's a long-standing story with immunotherapy that the smaller the tumor, the better the effect that you get. And this is all to do with immune tolerance and immunosuppressive environments around big lumps of tumor and so forth. So the other thing that we're doing as part of this is to say, okay, well, if the tumor is so small we can't actually see it on the scan, do we get a better biological effect? And there's a bunch of stuff we can measure in the blood that's not ctDNA that may be able to tell us whether we're seeing an increased biological anti-tumor effect in those patients as well. But that's a bit of a digression. I mentioned what Nick Turner's been doing with breast cancer, and we also see it in other cancer types, and effectively looking at that ctDNA in the tebentafusp trial that showed that you could halve the risk of death in people with metastatic disease is a type of therapeutic monitoring. But this is another example from esophageal cancer. This is what's called a waterfall plot. So if your tumor stays along the x-axis, it's not changed in size. Each plot, each bar is an individual patient. If the bar's pointing down, that's your tumor getting smaller. If the bar's pointing up, that's your tumor getting bigger. And then what you can see here is the overall outcome for the patient on the right-hand side, according to measurements on a CT scan. And the key thing and on the left-hand side, it's done with ctDNA. The key thing to look at here is that the colors are a bit more all over the place on the right than the left, saying that if you do a scan or ctDNA 4 weeks into treatment, the ctDNA will tell you much better than the scan what you're going to get at the end of treatment. So again, really interesting, probably not good enough to sell to a patient as a means of stopping treatment after 4 weeks on the grounds that you think it's probably not going to work. So for the last 50 minutes or so, what I want to talk about is how you diagnose cancer and how we might use ctDNA to do that. So at the moment, the way we diagnose cancer in the UK, and there's a report that came out at the end of last week that talks about this, isn't good enough. And that's partly because how we're set up as a national health service. It's partly how we as people behave in the UK. But what it means is that about a quarter of all diagnoses in any given year are with late stage, are in the emergency room, and far too many cancers are diagnosed at a late stage where the options for treatment and certainly for cure are very, very limited. Now, there are some where that's simply not the case. The screening program for breast cancer, the fact that melanomas are on the skin surface and therefore spotted relatively readily means that over on the far left, you've got some tumor types where we do pretty well already, even though we perhaps lag slightly behind our international peers. And then over here on the right-hand side, we've got a bunch of tumors, usually in the belly or in the middle of the chest, that we pick up really, really late. And in particular, esophageal or gullet cancer and pancreatic cancer, both of which have really bad outcomes in the UK and generally worldwide. And one of the ways we know that we should be able to do better with this is we can pick it up earlier when it's operable, when it's irradiatable. Not sure that's a word. When we can irradiate it, rather than relying upon drug treatments that are ineffective. Broadly speaking, it's just under 1 in 3 cancers that are diagnosed at stage 3, gone to the lymph glands, or stage 4, gone to other organs at the time of diagnosis. And so we've set up this series of rapid referral pathways, known in the jargon as 2-week wait pathways, that if you go and see your GP with a set of symptoms that has a 6% chance of being cancer or more, you should be shoved into one of these pathways, and at the end of 2 weeks, cancer yes or cancer no. And in some ways, it's a really great concept. It's moved diagnosis forward appreciably over the last few years, but it does have a couple of flaws. Like, one is we invite your GP to guess what cancer you might have, which can be very straightforward, but not always, which guides which test you have. And if you have, if the guess is wrong, then, if the guess is it's the gullet, then we stick a camera down and have a look at the gullet. Although I think you've heard from Professor Fitzgerald about how you might pop a sponge down instead. But obviously, if the tumour's in your pancreas, neither a sponge nor a camera is getting there, and you'll probably come back through the loop at a later date. So, circulating tumour DNA comes into this space. It's largely built around epigenetic rather than genetic mutations, for reasons I won't go into today. There's a whole bunch of different technologies doing it, and generally we're pretty good now at measuring stuff, to use the detailed scientific concept. And the battle really is about making sense of what we can measure. It's really cheap now to, the Sanger Centre down the road has sort of pioneered this. It's very cheap to measure stuff. Genomes that cost £1 million, a decade or two ago, can now be done for less than $1,000. And so we've got into an era where this is tractable for clinical testing. So we think about how cancer is diagnosed. We've got a bunch of cancers that we screen for, like breast cancer, like cervical cancer, like bowel cancer. We've then got these 2-week wait pathways, which is where the earlier referral for tests comes in. So a hair trigger for certain symptoms that gets you into the system. And then we're desperately trying to train people up with earlier help seeking for particular symptoms. And the main vehicle for this is soap operas. If you want to double the number of breast cancer inquiries in the Thames Valley, then somebody in EastEnders gets breast cancer, boom, for about 3 months. And we're all looking forward to the prostate wave, as I understand that the King has had a cancer diagnosis having gone in for benign prostate surgery. So that's going to see a spike. So, and then there are sort of more systematic symptoms to encourage usually white middle-aged men not to ignore symptoms that they shouldn't be ignoring and go and get help. So that's largely how we're trying to improve the situation. And what Simplify, the trial that we ran from Oxford, is concerned about is looking at how we could use multi-cancer tests in people who have symptoms. And what NHS Gallery, which is run out of King's by Peter Sassini, is doing is at the far left-hand side, is saying, well, let's just cut that out and let's just screen for cancer and see if we can just pick it up in the asymptomatic people before it causes trouble. So the sharp-eyed among you will recognize the picture here. So it uses circulating tumor DNA, so blood, plasma, fancy machine. It's a machine learning approach because these patients, we haven't got a tumor. They're ostensibly healthy. We've got to essentially have a classifier that tells us, do we see cancer or not? So the commonest outcome from this is we can't detect a cancer signal. And then some of the time it says, yep, we can detect a cancer signal. And okay, that's not, that's scary if you're the recipient of that, but not terribly useful. So importantly, it then tells you its best guess or best 2 guesses for where the cancer is. And as I'll show you in a minute, pretty accurately, which is important because, if you get the flashing red light, you've got to be able to do something about it. So we ran this study starting in 2021. We did it in a sort of slightly weird geography because we were second to the party. The NHS Gallery test was screening asymptomatic patients, and so we didn't want to go anywhere that they were, so as not to sort of have the same test testing 2 different problems in the same geography. So we went to Wales, we went to Thames Valley, down to the southwest parts of London, and up in Yorkshire. So we recruited 6,000 people who had been referred by their GP into one of these rapid diagnostic pathways. And essentially from the participants' perspective, when they came to hospital or a diagnostic centre to have their test, we basically doorstepped them there and said, would you like to have a blood test as well as having your regular investigations? It'll be of no use to you because we won't run the result until 6 months' time, when you'll have finished all your investigations, and we'll never tell you the result, but it'll help us. And amazingly, most people go, yeah, fine, and give us the blood. So very, very helpful. Now, what we're interested in, we weren't particularly interested in red flag symptoms because if you're coughing up blood, if you can't swallow, if you've got a lump in your breast, you're going to have that checked out. No blood test would, could, should stop you from having that checked out in the normal way. So really what we're interested in is all these non-specific symptoms, and can we more accurately say whether these require panic buttons or everybody can relax. So we had over 6,000 participants, and 800 of them, we either lost information by not being able to do a blood test, because this was sort of one go at getting the blood. We couldn't come back and take it at a later date if we couldn't manage it on the day. So that's how we lost most people. Or perhaps they didn't then go on to run through all the diagnostic pathway for their standard approach. But we ended up with nearly 5,500 people who'd been referred down one of these 5 pathways looking for either a gynecological cancer, a cancer in the upper or lower gut, in the lung, or had a vague symptom that the GP was worried about. And there's this system called rapid diagnostic centres that you can be plugged into straight away for that. So we diagnosed 368 people with cancer by conventional means. And by and large, what this slide shows, and ignore the colours, is that your GP is pretty good at guessing the right pathway. So most of the cancers came from the bit that the GP thought was wrong and had referred them down, with one exception. When you get to upper GI cancer, when you get to sort of symptoms that happen around here, that breaks down. And we saw cancers of blood, ovary, different organs in the upper GI set, in the bowel from that. And obviously in the rapid diagnostic centre, the GP just says, I don't like this. I don't know where the problem is. And what you can see overall is that means that the pathway is doing what it should. The trigger is 6% risk of cancer, and 6.7% of people in that pathway had a cancer. The blood test called 323 cancer signals detected, of which 244 had cancer diagnosed by conventional means. So that means it's relatively specific, but it's not terribly sensitive. So it's only picking up about 2/3 of the cancers. Okay. Now, come back to whether that matters or not. And then for those of you who like your statistics, the positive predictive value, the negative predictive value are there as well. But these are pretty difficult concepts to get hold of. So what I like to think of is the pre and the post-test probability. So if you're in our trial, you have a 6.7% risk of cancer, if you look at the top line there. If you had a positive test and you were in the trial, then the chance of you ending up being diagnosed with cancer was about 75%. If you had a negative test, then the chance of being diagnosed with cancer went down to 2.4%. Now, one of the things we hope that we might be able to do with the test is, so if you've got a negative test, your risk is so low, you don't need to have any tests. Well, I don't know about you, but if I had a 2.4% risk of cancer, I'd want to get that checked out. I wouldn't go, yeah, fine, don't need any tests. Whereas perhaps down at the upper GI end, you're now getting below 1%. We perhaps might be in the ballpark where we might think about not doing invasive tests. Now, this slide's important for the left-hand side. The blood test is much better at picking up late-stage cancer. So in that sense, it's a bit of a disappointment, because the whole point of this is to diagnose it early enough to be able to do something curative. And actually, if you look at the sensitivity at stage 1 and stage 2 cancers, down at sort of 20 to 50, high 50s%, not brilliant, but we come back to that. If we think about the symptoms rather than artificial diagnostic constructs, then I think it gets a little bit more interesting. You can see quite a bit of variability, but you could see how if you've got somebody with a particular symptom, not in this group of people where the risk of cancer is about 7%, but in other circumstances where you might be able to use this sort of test to discriminate. And then in terms of telling you where to test, it was actually pretty good. So if it's on the diagonal, then it got it right. You can see that there are a few bits that are off the diagonal, and some of those are explained biologically. So cervical cancer and head and neck cancer are kind of similar because they're driven by HPV, and so is anal cancer as well. So when you're miscalling that, you can sort of think of a biology that tells you that. And then hopefully, you can make your own joke, but the ability to distinguish between the cancer in the anus and in the head might be, that might be clinically tractable. You'd hope, anyway. So there are some issues with this test, and this is something also that we need to think about. That late diagnosis of cancer is spread unevenly across the population, and so what we had to do, though less because our population was already seeking help, but Peter Sassini's had to do in the screening thing, is make sure that this blood test isn't just done by people who shop at Waitrose, pay attention to their health, and they're probably going to access healthcare pretty accurately and quickly in the event of symptoms. It needs to get into populations who don't trust healthcare, have taboos associated with cancer, and therefore will actively avoid it if they think that that's the potential diagnosis and so forth. And so King's have done a lot of work around this in the NHS Gallery trial about how you reach the right population so as to really shift it. We also worry about behavior after a negative test. If you have a negative test, does that mean that next time you get a symptom, then you ignore it? As I like to tell my patients, you've got a negative CT scan. They go, oh yeah, that's great. No. What a negative CT scan means, if you want to be a real downer, is it? There is no tumour on the day, at the hour in which you're in the scanner, that's more than 15 millimeters in diameter in your body. That's all it says. And so what the negative test says is, the post-test probability is quite low that you've got a cancer, but as I showed in some of the previous things, it's not zero. And then the other big problem is that you make everybody a patient with the false positives. And there's this real issue of how do you clear a false positive? What would convince you want to think about this as your homework? If I do this test and it comes back cancer signal detected, what would I have to do to convince you that was a false positive before you said, okay, I can relax now, I can go back to being the normal me? And that's quite a tricky thing to think about. And as I said, the test wasn't a good way of stopping us from doing things like scans and endoscopies, therefore big problem about creating additional demand rather than driving it down. The other screening study, way bigger than our trial, over 100,000, I think it's about 120,000 participants. And it's in the asymptomatic population. And it's asking as its first question, if people go into this program and have iterative tests over a couple of years, does the stage at which cancers are diagnosed in that cohort go down? And that's a surrogate endpoint. It's an early endpoint that drives a decision by the NHS to buy a bunch of tests to do a bigger field test of the test. But ultimately, the trial is designed to look at whether people survive cancer better and for longer. And there's been some correspondence in the Lancet with a bit of a sort of classic academic storm in a teacup that settled down a couple of weeks ago, if you want to look at that. And so for the final couple of minutes, I just want to talk about, to my mind, what's one of the most exciting aspects of this technology, that if we can get the right funding and get it to the right people, could really change the game for people who, if we're wringing our hands about our cancer outcomes here, it is as nothing if you go down to Tanzania and Kenya and Uganda and so forth. And part of the problem there is they haven't got the infrastructure. It takes a long time to train doctors. If you send them over here and train them, they often don't go back. Or if they do, they wait a long time before they go back. There's a lot of high unmet need there. And you have to be slightly careful because it's no good diagnosing a bunch of cancers you can do nothing about. But there are also areas where you could meet the need if you were better. And then also you don't want to be the white savior who goes in and does something really fancy, all Oxford and Cambridge, and then wanders off and expresses mild surprise that it doesn't work in Dar es Salaam. So it's about making sure that you've got sustainable local solutions that can survive any research project. So what Anna Shu, one of my colleagues in oncology in Oxford, has been doing is looking at how you could use ctDNA technology to diagnose childhood leukemia and lymphoma, which is often driven by Epstein-Barr virus. So Burkitt's lymphoma is the classic example. And at the moment, you have to find somebody who can take a sample of the tumor. It's often quite a big tumor, so it's often a bit mushy on the inside. So it's often the biopsy is non-diagnostic and has to be repeated. That has to be sent usually to the capital because there are very few pathologists. And it has to arrive intact. There has to be a pathologist to read it. There has to be a readout, and it takes months sometimes to diagnose this. And these are conditions that in some circumstances can be treated with cheap, simple drugs quite effectively. So what Anna has set up is that you can take blood. Blood is easily transportable. The nice thing about circulating tumor DNA is you can send the blood in the post in the UK, even our post, even if it goes down to 3 days a week. But you can send it to the capital. All the technology is there to extract the DNA, to do the sequencing. It was all massively upscaled for COVID and for tracking that. So they've got the sequences, they've got the skills in-house and all the rest of it. And at the moment, the only bit we really provide from Oxford isn't even the bioinformatics. It's sort of marking the homework before the test gets signed off. So what that means now, and I visited back last summer, and when I arrived, they'd just done a diagnosis of somebody in rural Uganda who'd had the blood drawn on the Tuesday. I arrived on the Saturday. They had the diagnosis of Burkitt's lymphoma. They could start cheap chemotherapy based around doxorubicin. And as you can see here, this isn't for everybody, but bottom right, you can get some pretty spectacular results with that. As I say, what we want to do is to do this for the long term. So this is done in conjunction with the Ministry of Health. What you see bottom left is a social enterprise designed to develop that it's largely based around Tanzania, but with a sort of Tanzanian specific approach that works for them. As I say, all of the processing is done at one of the hospitals in the Central Public Health Laboratory in Dar es Salaam. So in summary, I think ctDNA has a bright future for cancer care. It's going to be highly disruptive to current practice, and it's got a bunch of applications which I've touched on. There are some really rapid technological advances which make implementation challenging because the trials that I've talked about, some of them take years, and the technology moves by the time you get to the end of your trial. That's exciting because I think the general principles you can then work into the trials and say, well, if I had a test with these characteristics, my trial would have changed in this way. So you can do in silico or modeled trials, if you like, as well. The biggest risk, though, is of overselling, risking take-up. So at the moment, we're taking a systematic approach to the Gallery test that's marketed by Grail, but it is already being sold in some territories. And with the benefit of observational studies, but not the sort of trials that I presented here. So I think that's the biggest concern, though, is that if the early trials with this technology yield equivocal results and we lose the public trust in the technology generally, then it's going to be far harder to implement it. But it's the kind of radical, large-scale change that's going to be needed if we're going to be able to manage cancer with ever-increasing numbers in an ever-aging population in a way that current systems in the NHS simply can't cope with if we carry on doing the same thing. And I think we'll stop there with just some acknowledgements of some of the people involved in some of the work that I've presented. Thank you.
Well, that was stunning, Mark. Thank you very much. Are there some questions from the audience? There's one there. Thanks.
Hello, thank you very much indeed. I was just considering the completely asymptomatic patients in terms of three factors: genetic makeup, family history, genetic makeup, family history, and age. Would you care to put these into your treatment? How would you consider those as in a cost-effective framework? Thank you.
A remarkably complicated question. I think that a screening approach deliberately tries to simplify these things and say, we're going to take a really big cohort and do the same thing to everybody. So of those factors, the screening approach basically says age is the only thing I'm going to take into account. There is little point in screening 20-year-olds for cancer who are asymptomatic. It's not common. Most of the cancers they get are pretty weird, and therefore we're not clear how the test performs. So NHS Gallery has age parameters. I'm not part of the study, so I don't recall them. And since this has been recorded and going on the web, I won't hazard a guess and put some false information out there. You can look it up. I think when you're thinking about high-risk populations, we already do high-risk situation-specific screening, whether that's familial polyposis in colorectal cancer and looking with more endoscopies. So I think what we would see in those situations is disease-specific testing built around the particular biology. And that's a little bit like the approaches I've shown for uveal melanoma, for cutaneous melanoma, where you can adapt the technology in that way rather than doing a formal screening approach.
Hello, thank you so much for the talk. I really enjoyed it. I'm curious, so this is not yet the stage where you can kind of communicate to patients what this might mean for their health, right? So you haven't gone to that, I guess, stage of development. I was wondering how you might communicate the risk of disease to patients who show up with, let's say, a positive test result, and how that might differ between the UK context and the LMIC contexts where you might apply this with a similar technology. Thank you.
So in the UK context, what we're very clear about saying is this test does not diagnose cancer. This test points the physician at doing what we would normally do to diagnose a cancer, which is to identify the lump, the lesion, and take a sample of it. So that's the UK and the Western Hemisphere construct, if you like. And as far as low and middle income countries are concerned, we're then going a different way and saying, well, actually, we're going to tailor the test to be diagnostic, to say this is the diagnosis. You don't now have to do pathology, because the problem we're addressing there is no pathologist to do the pathology. So we need an informatic, an analytic solution to address a different problem. So different answers, if you like, for different situations.
Thank you very much. I can bring a great deal of ignorance to bear on this subject, but I've only just realized that the cancer cells can mutate and thus have escaped from the treatment that is working. So can your system detect when that happens, or can it go further and detect which treatment would be better?
In theory, yes. And there are trials going on looking at that specifically. So for many years in lung cancer, we've had inhibitors of the epidermal growth factor receptor, EGFR inhibitors. And one of the recognized methods of escape is a particular mutation that can then be targeted with a different generation of EGFR inhibitors. So there are trials about triggering that through ctDNA. And other studies of that ilk. The problem there is if you know what you're looking for, and obviously in lung cancer, that's a relatively well-developed concept, then some of these approaches are relatively straightforward. If you're asking a more general question about the emergence of resistance with non-targeted treatments like immunotherapy, like chemotherapy, I think that's going to be a much tougher nut to crack. You might be able to say generally this is going in the wrong direction, but that's very different from then saying, and the answer is this because the biology of the ctDNA tells me so.
I've got an online question here, or two questions, a couple of compliments online, by the way, as well. Thank you for the great talk. I have two questions. For tumour-naive methods for early detection, what would be the strongest biomarkers? For example, methylation, fragment length, proteomics, etc.
Well, therein lies the intellectual property of dozens of firms. At the moment, with multi-cancer detection, the field does seem to be coalescing around methylation rather than genetic mutation, as I mentioned in the talk. There are some fragmentomics approaches as well. And I think there are other groups that are interested in inputs other than purely nucleic acid. So to my knowledge, Exact do that with some of their tests, is to take into account the proteome and other inputs. And we're interested in, and will publish on this later this year or next, looking at what other factors, test results, demographic, and so forth, bear on the post-test probabilities with the Gallery test in our population in Simplify. And obviously, as I mentioned in the talk, you know, we're getting pretty good at measuring stuff now. And the race is now to make sense of what we measure. Whereas, you know, when I started, you know, sequences would chunk through, you know, often do a base in a couple of minutes and things like that. You know, so the race then was to be able to measure more stuff, because that way lay you know, numerical power and so forth. Whereas now it's about making sense of what we have. And so the issue there becomes, you can tune these tests, but the central problem around early detection is that every time you make something more sensitive, it comes at the cost of specificity. So it's not necessarily about how well you can do these things. It's probably about non-test parameters, like what the public will wear, what are the triggers for doing things like scans and scopes and so forth, rather than the intrinsic qualities of the test or the inputs that get you there.
Okay, thanks. And the second part, would you think that cell-free DNA from other body fluids such as urine might be promising biomaterials for cancer detection in the future?
Yes, I mean, urine in particular, and you know, bladder cancer is a very specific problem where there are lots of people with early bladder cancer who have to have repeat cystoscopies to look for new lesions. And clearly, there's been a lot of work done over the years looking at either immune cells or volatile organic compounds, and now DNA fragments as the basis for doing that without having to repeatedly scope people, which is very uncomfortable. So, you know, I think saliva and urine in particular, probably unlikely to be CSF. It's quite hard to get hold of. But you know, other fluids for sure will yield to this approach as well. I mean, we've still got a lot to learn about, you know, where tumor DNA ends up in most quantities and so forth. So the fairly basic stuff like that, to understand whether just, you know, sticking needles into usually people's elbow is going to be the right way to go.
It seems reasonable that bladder cancer would be susceptible to a urine test, though, doesn't it? Yeah.
Although we have been saying that for a number of years without ever quite getting away from cystoscopy.
Right. One more question in the audience.
Very encouraging indeed, your work. I congratulate you. I was interested in what you're doing in Dar es Salaam, because how you're targeting your specific speciality of melanoma because of the climate, etc. And are there climatic conditions which make a particular cancer predominant, and therefore it's a very international experiment, as it were, at this stage?
Sorry, I should point out, we're looking at childhood leukemia and lymphoma, which is, you know, a very, very specific problem in that region. The cancers that predominate in sub-Saharan Africa are breast cancer, cervical cancer, head and neck tumors associated with tobacco and betel chewing and things like that. So it's a slightly different set of diseases from the ones that we encounter in the West. And so any approach will have to be linked to that. That isn't to say that, you know, the approaches that we take in the West won't work there, but I think they'll be less impactful because they've been tuned to Western diseases, which are often in the cancer setting now, diseases associated with obesity and plenty and so forth, which aren't the things that pertain there. So I think, you know, this will be a whole suite of different tests and approaches in a variety of different situations. I think when it comes to, you know, East Africa in particular, what we want to focus on with the help of the doctors there is things that can then be acted upon. It's no good running around naming problems that are then beyond treatment. And, you know, if we think about breast cancer, we think about cervical cancer, if we think about childhood leukemia, there are effective treatment approaches that we can use in those situations. And that's why I think it's right to think about how this technology might be used.
That sounds like a very similar problem to that of water supply, where if you go to an African village and install a really complicated water pump and then go away and it breaks, you're back to square one. Are there any other questions? I have one question. And oh, there's someone right at the back there. Robin?
Hi, thank you for your talk. It was very interesting. I was just wondering, with the Simplify trial and the MZ tests, is there any concerns for using machine learning as kind of like black box model in terms of it biasing the kind of false negatives and false positives in terms of the population that you get who are entering in the trials, if that makes sense?
Yeah, I think that's a very real risk, and it's one that, you know, the NHS is alive to, and why, you know, there have been strenuous efforts to make sure that it's evaluated in populations other than you know, white people with, you know, relatively homogeneous European genetic stock. That then might not speak to ethnic minorities or to particular risk factors that pertain to you know, socially economically deprived groups. You know, I think that's a strength of the stepped approach that NHS England want to take, which is to say that, you know, a positive surrogate marker means that the NHS will invest in 1 million tests over subsequent years. And, you know, that's not then the end of the story. It's not the sort of the nice thing with drugs where, you know, you get the tick in the box, you can sell the drug for the rest of the patent life. It is, we will buy these tests and we will use them as a field evaluation of the technology at scale. And, you know, that's a risk sharing approach which starts to address some of the issues you've highlighted, that, you know, there are biases inherent in any of these approaches that need to be addressed. And I think at the moment, you know, NIHR has got bids out to tender for working on that set of data, assuming it's going to arrive and be triggered. So I think that, you know, you can't evaluate all of these things even in a trial of 100,000. It needs more and more and more. And, you know, I think these tests will continuously evolve and will need, you know, to be developed in multiple different territories and multiple different populations before we understand whether there are unifying principles behind them or whether they really are very, very specific. And obviously, if we've got black box machine learning approaches, then the idea of unifying principles is lost to us because by definition, it's in a black box. but that's not the only way in which this can be done. And I hope I've shown a few other methods that can be used that are at least biologically tractable and can be interrogated in that respect.
Okay, well, I have probably a final question, given the time. In the US last year, there was a very high-profile court case of someone committing fraud through a multi-disease detection test. Elizabeth, someone, I can't remember.
Yeah, Holmes.
And has that poisoned the atmosphere for these multi-disease tests, do you think?
Well, when we reported the Simplify results, apart from the fact I spent 25 years in cancer research with nobody paying the slightest bit of attention to what I do, and then suddenly for about 15 minutes, very Andy Warhol, everybody wanted to know about everything. The Elizabeth Holmes question did come up. I think the difference that we've got, and I say we in the general sense, is we presented 6,000 patients worth of data. Grail have got tens to hundreds of thousands of patients worth of data, as have multiple other companies. I think that we understand in the field what data is, and sometimes the investment community runs ahead of itself slightly because they're driven by the fact that if you want to make big money, you have to kind of get in almost before the data are there, and that's a risk. But this is a very different proposition. Grail, Illumina, Exact, these are serious companies investing seriously in the data. They're putting it up there to be interrogated publicly, as and when they can, whilst preserving commercial confidentiality. It's just not the same thing at all.
Good. Okay. Thank you all for your attention. Well, thank you for a fascinating talk, Mark. That's been really interesting. Thank you again for trekking so far to come and see us, and I hope you have a safe journey back.
Thank you.